If I told you that the future of treating severe, irreversible tissue damage involves harvesting the reproductive material of a salmon, you'd probably think I was pitching a bizarre sci-fi novel.
Right. I mean, it sounds completely surreal when you put it like that.
It really does. But in modern regenerative medicine, that is exactly what's happening right now. We are talking about using highly purified marine DNA to essentially hand our own dying cells a box of recycled spare parts.
Yeah, and utilizing these DNA fragments is just completely changing our approach to tissue regeneration. We are no longer just, treating the symptoms of aging or tissue damage. We are actively supplying the raw biological materials needed to rebuild that tissue from the inside out.
Okay, let's unpack this because the stack of sources we are exploring for today's deep dive is just wild. We've got aesthetic medicine guidelines, highly technical biomolecule reviews, and clinical studies on severe tissue atrophy.
Oh, it's a massive amount of data.
It is. And the mission for you listening today is to synthesize all of this to answer a highly specific but honestly revolutionary question. What is the exact role of specific polynucleotide chain lengths in signaling cellular repair and long-term hydration in atrophic tissue?
It's the multi-million-dollar question right now. I mean, both in aesthetic and regenerative medicine, there is massive excitement around these treatments, but there's also just deep confusion.
Right, because the market knows these treatments work, but there's a profound lack of understanding about the mechanics, like why they work differently depending on the specific product used.
Exactly. And that seems to stem from the interchangeable use of two acronyms, which are PDRN and PN. You see them slapped on everything from luxury skin boosters to intensive medical wound treatment.
Yes, they are everywhere. But to figure out how these molecules actually rescue dying tissue, we have to look at what they actually are. So our sources state that both polynucleotides, or PN, and polydibonucleotides, PDRN, are highly purified DNA fragments.
Right. And they are extracted primarily from the gonads, specifically the sperm cells of salmon and trout.
Which is where that sci-fi element comes in. Like salmon spine.
I know. But there is rigorous biological logic behind this. The DNA from these specific fish shares over 90% genetic similarity to human DNA.
Oh, wow. Over 90%.
Yeah, it's incredible. Now, you might wonder why the human immune system doesn't immediately attack it as a foreign invader. The secret is really the purification process. The manufacturing extracts the raw DNA, but violently strips away all the immunogenic proteins.
So things like histones or peptides that would normally trigger an immune response.
Precisely. What you are left with is just the naked, highly biocompatible double helix structure.
That is fascinating. But I still struggle a bit with how the medical community managed to get so hopelessly confused by the terminology. I mean, for years, major clinical papers were using PDRN and PN to mean the exact same thing.
Yeah, they were treating them as synonyms, which completely masked the underlying science. This negligence actually led to a recent, incredibly important paper in the journal Biomolecules. They proposed a standardized, structure-based nomenclature called the Marquis polynucleotide cutoff.
Right, the Marquis cutoff.
Yeah, they basically drew a hard, non-negotiable line in the sand based on molecular weight, specifically at 1,500 kilodaltons, or K-day.
Okay, so under this Marquis cutoff, PDRN refers strictly to the smaller fragments, basically anything under 1,500 kilodales. These are the short and medium chains, typically about 10 to 30 nucleotides long.
Yep, you've got it.
And PA is reserved exclusively for the massive polymers over 1,500 kilodalton. So if I'm visualizing this correctly, it's like the industry has been confusing cousins with twins, you know?
That is a great way to look at it.
Like if our skin is a damaged, crumbling house, it sounds like PDRN is the emergency repair crew bringing in spare parts, while the massive PN molecules are the heavy architectural scaffolding required to hold the walls up.
What's fascinating here is that distinction is the entire foundation of how this science works. The physical size, like the literal length of the biological string, entirely dictates its biological job.
So size literally determines the function.
Exactly. It determines whether you are injecting a fast-acting pharmacological signal or installing a long-term structural foundation.
Okay, well, let's dig into that emergency repair crew first, the short game. Wait, if these PDRN chains are so small, doesn't the body just treat them as microscopic waste? Like, wouldn't it just flush them out before they can even do anything?
Well, that rapid degradation is actually the intended mechanism. Because PDRN chains are under 1,500 kilodE, Their low molecular weight allows them to penetrate tissue with incredible ease.
Okay, so they get in quickly.
Right. But you are right. They are immediately targeted by endogenous nucleases. These are the natural enzymes in your body that patrol for loose DNA and basically chop it up.
So they don't survive long at all in their original form.
No, not at all. But they aren't supposed to. As those enzymes aggressively chop up the PDRN, they release thousands of tiny nucleosides and nucleotides into the surrounding tissue.
And those fragments do the heavy lifting.
Exactly. These microscopic fragments immediately bind to specific receptors on your cells, specifically A2A receptors. And these are highly concentrated on fibroblasts, which are the cells responsible for producing your collagen and elastin.
Right, and the moment those A2A receptors are triggered, the sources describe an absolute cascade of activity. It stimulates the synthesis of type I and type 3 collagen.
It sure does.
And it boosts vascular endothelial growth factor, or VEGF, which triggers the creation of brand new blood vessels, a process called angiogenesis.
And perhaps most importantly for damaged tissue, it suppresses NFB.
Wait, NFPB? Tell me more about that.
So, to put that in perspective, NFB essentially acts as the master genetic switch for inflammation in your cells. By flipping that switch off, you are instantly silencing the cellular alarm bells.
Oh, wow. So within a very short window, you are flooding the area with new blood flow, forcing collagen production, and executing a massive drop in destructive inflammation.
That's the short game in a nutshell.
The papers also detail something called the salvage pathway, and I'll be honest, this is the part that genuinely blew my mind. I am having a hard time wrapping my head around the fact that human biology allows cross-species spare parts to function as human cellular fuel.
I know, it is an absolute evolutionary marvel. Normally, if a cell is damaged or starved of oxygen, it has to rebuild its own DNA or create new proteins from scratch.
Which is known as de novo synthesis, right?
Yes, exactly. And that requires a massive amount of cellular energy, which we call ATP.
But if a cell is already damaged or dying, it doesn't have a massive reserve of ATP just sitting around.
Precisely. The cells are essentially running on empty. They want to repair the house, but they don't have the metabolic fuel to manufacture the bricks.
Makes sense.
But with PDRN, you are flooding the environment with pre-assembled DNA fragments. The damaged human cells recognize these salmon-derived fragments and just scavenge them.
They just take them in?
Yep. They salvage the injected DNA and seamlessly recycle it to repair their own cellular structures. It bypasses the energy-intensive manufacturing process entirely.
It's literally handing the cells finished bricks instead of asking an exhausted, dying cell to bake the clay itself. That is incredibly efficient.
It really is.
But there's an obvious flaw with just relying on this emergency repair crew. Once the enzymes chop up the PDRN, the A2A receptors quiet down, and the SOS signal fades. So what stops the chronically damaged tissue from just collapsing again?
Right, you need something permanent. Which leads us to the long game.
Yes, the PN molecule.
Exactly. This is where we move past pharmacological signaling and enter the realm of structural engineering. This is the domain of the long-chain PNs, the molecules over 1,500 kiloday.
And these behave totally differently in the body.
Completely. Unlike the small PDRN fragments, these long chains possess extreme viscoelasticity. When they are injected, they don't just diffuse and get eaten, they spontaneously tangle and reorganize themselves into a three-dimensional, porous, hydrophilic scaffold.
Hydrophilic meaning it aggressively attracts water. And the physics of this are wild. The sources note there are 2 molecules of water permanently bound to every single nucleotide in that massive chain.
It's a huge amount of water retention.
Yeah, because the PN chains are so massive, they act as deep tissue reservoirs. They're just holding immense volumes of water locked within the extracellular matrix.
Which is a completely different mechanism than what you see with standard skincare ingredients, like take hyaluronic acid or HA, for example.
Here's where it gets really interesting. If HA is like chugging a glass of water for a quick temporary fix to dehydration, PN sounds like installing a slow drip irrigation system that also actively rebuilds the soil structure.
That analogy perfectly highlights the mechanical difference. Hyaluronic acid is fantastic for immediate moisture, but it is passive. It doesn't permanently change the architecture of the tissue.
Right.
The PN scaffold, because it forms this dense physical 3D mesh, structurally redistributes mechanical tension within the dermis.
But how does physical tension actually help a cell, though?
It happens through a process called mechanotransduction. Fibroblasts are highly sensitive to their physical environment. Imagine trying to build a complex structure while standing on a sinking swamp versus a solid concrete foundation.
Oh, so they need something to grip onto.
Exactly. When the PN scaffold provides that tense, hydrated physical foundation, the fibroblasts physically stretch out and anchor themselves. This mechanical stretching actively signals the cell to thrive and produce structural proteins.
Wow. And because these PN chains are so long and robust, it takes those endogenous nucleuses months rather than days to break them down.
Yep, you get a sustained, slow release of those nucleoside repair signals while simultaneously maintaining a physical, waterlogged scaffolding for the cells to live inside.
That is incredible. But let's step away from the cosmetic side for a moment, because what we're really talking about here isn't just smoothing out wrinkles.
Definitely not.
The most profound application in these clinical papers is how this exact science is utilized to rescue dying, atrophic tissue in incredibly severe medical scenarios.
Yeah, and the clinical reality of vulvovaginal atrophy, or VVA, is a perfect example of this. It's an incredibly common but frequently silenced condition.
Right. And while it's primarily caused by the natural physiological decrease in estrogen during menopause, our sources focus heavily on patients experiencing iatrogenic menopause, meaning it is medically induced.
Which is often the case for cancer survivors.
Exactly. We are talking about women who are survivors of cervical, endometrial, or colorectal cancers. They have undergone aggressive chemoradiotherapy, and the radiation and chemotherapy have completely devastated the local pelvic tissue.
The symptoms described in these papers are agonizing. Severe dryness, the physical thinning and fragility of the skin, to the point of caring, intense burning, and dyspareunia, which is severe pain during intercourse.
It sounds like a total disruption of a woman's quality of life after she has already survived cancer.
It really is a devastating structural collapse. The tissue has lost its extracellular matrix, the collagen and elastin fibrils have degraded, and the mucosa has entirely lost its ability to retain moisture.
And normally, VVA is treated with localized estrogen therapy, right?
It is. But for cancer survivors, especially those with hormone receptor-positive cancers, introducing estrogen can be incredibly dangerous. It's often strictly contraindicated.
Which leaves these patients with almost no options until this DNA-based approach. The sources reveal that treatments combining these massive long-chain PNs with hyaluronic acid are showing groundbreaking non-hormonal results.
And these are administered via vaginal ovules or targeted submucosal injections. The mechanism is entirely structural and regenerative, completely bypassing the endocrine system.
That's huge.
It is. The clinical data shows that these DNA scaffolds actively regenerate the dermal and submucosal extracellular matrix. They physically thicken the tunica propria, the vital connective tissue beneath the surface, and restore elasticity to tissue that was essentially dead.
For you listening, you might be wondering, if long-chain PN is this powerful at rebuilding tissue and locking in water over the long term, why do these clinical formulations bother mixing it with hyaluronic acid? Like, why not just use pure PN for these VVA treatments?
If we connect this to the bigger picture, it comes down to the immediate biological survival of the cells in severely atrophic environments. Fibroblasts simply cannot survive, let alone synthesize new collagen in a bone-dry, desiccated environment.
So they just shut down completely.
Yeah, the tissue in severe VVA is so depleted that the cells are essentially dormant, just dying of thirst.
So the hyaluronic acid acts as a rapid life support system.
Precisely. The HA provides an immediate, intense surge of hydration. It buys the tissue time. It creates a wet enough environment for the fibroblasts to survive and wake up.
Oh, that makes so much sense.
Right. Once that immediate crisis is stabilized by the HA, the slow-release PN scaffold can take over the heavy lifting of long-term structural regeneration and continuous nucleotide signaling. It is a brilliantly synergistic design.
It really is. And we are seeing this exact same synergy applied across other medical fields, too. In aesthetic medicine, these same molecular principles are being used to treat iatrogenic fat atrophy, physically remodel deep, tethered acne scars, and even restore the structural tensile strength of the retaining ligaments in the face.
It's versatile, but the manufacturing side of this is where things get tricky.
Oh, absolutely. Before you rush out to find one of these treatments, we have to talk about the physical reality of manufacturing these products. Because if chain length dictates the entire biological outcome, how can you be sure what is actually inside the syringe or the serum?
This is the crucial hidden variable that the industry doesn't like to talk about. Producing long-chain PN is highly complex and up to twice as expensive as producing short-chain PDRN.
Twice as expensive. Wow.
Yeah, and the extraction and formulation processes are perilous because DNA polynucleotides, especially massive polymers, are sparingly soluble in water. They naturally resist dissolving.
So to force them to dissolve into an injectable hydrogel or a topical cream, manufacturers have to use aggressive methods, things like high heat or intense shear forces, like industrial magnetic stirring or vortexing.
And this is where the disaster happens. A 1,500 kilodalton polymer is literally a massive, fragile biological string. When a manufacturer uses high shear forces like a magnetic stir, the physical friction in the fluid acts like microscopic scissors.
Microscopic scissors, that sounds bad for a long chain.
It is. If the manufacturing environment is not perfectly meticulously controlled, that physical stress literally snaps the massive PN chains into thousands of short PDRN fragments.
So what does this all mean? It means a clinic could purchase a premium product marketed as a high-viscosity, long-chain PN scaffold. But if the lab mishandled it, they are unknowingly injecting a fast-degrading PDRN into the patient.
Exactly. What you could call a short chain soup. The practitioner thinks they are installing long-term architecture, but the patient's tissue just experiences a rapid flash of SOS signals that degrades in a few days. You entirely lose the mechanical tension and the structural benefit.
Although, ironically, there are times when manufacturers intentionally want that short chain soup, right? For topical serums and creams designed to be rubbed onto the skin, our sources point out that they intentionally aggressively break the chains down to under 50 kilonA, or even ultra-low weights like 1 kilonA.
Right, because the physics of the skin barrier demand it. A massive 1,500 kilonA chain physically cannot penetrate the stratum corneum.
So it just sits there.
Yeah, if you put a long chain PN in a topical cream, it is practically useless for deep cellular repair. It just sits on top of the skin, acting as a superficial moisture barrier. To get the nucleotides down to the living fibroblasts in the dermis, they have to formulate nanoparticles or ultra-low molecular weight PDRN to ensure permeation.
So it all comes down to knowing exactly what you are paying for and matching the tool to the site, which is why transparency from these companies is absolutely vital.
It is the single most important question a practitioner or a patient can ask.
If you are evaluating a regenerative treatment, you have to look past the luxury marketing buzzwords and demand to know the molecular weight disclosures, because the chain length is the sole dictator of the physiological action. If a brand hides their KD range, you have no scientific basis to predict how it will behave in your tissue.
Absolutely, you have to demand that transparency.
To bring this all together, utilizing marine DNA isn't just slapping a trendy, exotic ingredient onto a label. It is wielding a highly calibrated biological tool. Short-chain PDRNs act as quick chemical messengers.
They're the emergency repair crew rushing in to shut down the NF-key inflammation switch and spark new blood vessels.
Right. Meanwhile, long-chain PNs act as structural, water-retaining scaffolding, doing the heavy engineering required to physically stretch fibroblasts and reverse severe tissue atrophy over months. And the dividing line between the two is that 1,500 kiloday Mark's cutoff.
Which is exactly what allows modern medicine to tailor the intervention to the specific crisis the tissue is facing.
So whether you are looking into aesthetic skin boosters to rebuild collagen, wound healing protocols, or life-changing therapies for postmenopausal tissue health, you now have the molecular knowledge to see through the hype. To ask the real question, what is the chain length?
But if we look to the future, this raises an important question. There was a detail buried in the biomolecules paper we reviewed that hints at where this is all going, and it's almost terrifyingly exciting.
Oh, I know the part you mean.
It noted that DNA-based hydrogels possess the innate ability to probe, program, and reprogram diverse biological systems.
That phrasing, program and reprogram, it sounds like computer engineering, not a medical hydrogel.
Well, because fundamentally DNA is code. Right now, we are using these massive DNA scaffolds somewhat bluntly. We use them to passively lock in water, and we rely on the mechanical tension to trick our fibroblasts into waking up and making collagen.
So we're just using the structural properties of the molecule right now.
Exactly. But the paper suggests a massive evolutionary step.
Mm-hmm.
How far are we from programming these exact same polynucleotide chains to carry localized, highly specific genetic instructions?
Wait, really? So instead of just providing the recycled bricks to fix the broken house?
We provide the bricks,
Yeah.
but the bricks carry the blueprint to fix the foundation themselves.
Wow.
Imagine injecting a hydrogel that doesn't just passively patch up damaged tissue or mask the symptoms, but actively recodes the underlying cellular dysfunction that is causing the atrophy in the first place.
Okay, that is definitely something to chew on. From recycling marine DNA just to supply the physical parts to literally reprogramming the destiny of our own failing cells, it is an incredible frontier. Thank you so much for joining us on this deep dive. Keep asking the right questions, and we'll catch you on the next one.